I'm Andrew Carlo. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences at Northwestern Medicine. I see patients in my adult psychiatry outpatient clinic and also as a consultant in the primary medical setting. And secondly, I do research in the department, and my research mostly focuses on integrated behavioral and physical health care in the primary medical setting. We have learned through evidence that depression, anxiety, and substance use disorders are very common, cause immense lost productivity and suffering for patients and their families. The good news is that we have a lot of evidence-based treatments to treat these common problems. The bad news, though, is that we often don't get the treatments to patients who need them and when they need them. First and foremost, there's a large stigma that's still associated with mental health. We've tried to mitigate this in recent years, but it's still a major problem. Secondly, there just aren't enough behavioral health specialty providers nationwide, particularly in rural and underserved areas. Third, patients often aren't able to follow through with recommendations made by primary medical providers. Integrated care aims to mitigate some of these challenges by providing mental health and physical health care under the same roof. This allows people to leverage ongoing relationships with their primary medical providers. It also reduces the stigma associated with going to see a specialty mental health provider. And at the same time, it allows mental and physical health problems to be treated by the same people at the same time, which we know from years of evidence is a better way to treat chronic disease. Most of my research on integrated care has focused on implementation and sustainability across diverse populations and settings. One recent study that I finished shows that we can actually implement integrated care models in rural areas throughout the western and northwestern United States in federally qualified healthcare centers and still end up with good outcomes for depression and anxiety among patients in those settings. That was a major finding because most of the studies before that had been done in randomized controlled settings. Other research that I've done recently has looked into the usefulness of novel billing codes for integrated care models. And what we found is actually that these billing codes do in fact help move integrated care models toward financial sustainability over the long term, which was always a barrier of integrated care models. I've also done some advocacy work recently on mental health parity. For decades, insurance companies have and continue to manage mental health conditions differently than they manage physical health conditions. I think it's really important that we have parity and that insurance companies manage both of those types of conditions equally. We've continued to pursue our understanding of the neurological and biological underpinnings of mental health, which has made a huge difference in the field and will make a bigger difference in the future. Additionally, we've developed and we've rolled out novel therapeutics, such as ketamine for depression. There's a lot of ongoing research on the possible use of psychedelic medications in mental health treatment, and that's something that we anticipate will be a bigger part of treatment in the future. On top of that, we've worked really hard to evaluate and roll out new telehealth and digital health technologies that are able to provide care to people on their own at any time. And very importantly, our field has done a better job of understanding, acknowledging, and studying racial and ethnic treatment disparities in mental health care delivery. And the research is helping us come up with new strategies to mitigate and eventually eliminate racial and ethnic treatment disparities in mental health care delivery, which is a critical component of the future of behavioral health services.